system in pediatrics, the cardiovascular system. And the first topic that I'm going to be talking about is innocent murmurs in the children. Innocent murmurs. Murmurs, innocent murmurs are those murmurs which, when heard on auscultation, do not have any sequelae, do not have any complications, are harmless to the children. So how do you define an innocent murmur? What are innocent murmurs? Innocent murmurs are never diastolic. They are never diastolic, and they never have an intensity, never have an intensity of greater than 2/6. That is, the murmur can be heard clearly, but not very loud and not associated with a thrill, 2/6 in intensity. And these murmurs, these innocent murmurs, are ejection systolic murmurs or mid-systolic murmurs, and they occur due to flow of blood in the various chambers of the heart and from the chambers into the vasculature. So, and they are also called as flow murmurs. Because they occur due to flow of blood, they are also called as flow murmurs. And patients with innocent murmurs are asymptomatic, and these murmurs are usually found on routine examination of the child. These murmurs usually occur in an age between 3 to 7 years of age. They occur between 3 to 7 years of age, and all the laboratory investigations, if you perform an echo, if you perform any investigation, it will be normal, and no treatment is necessary for these patients. All that you require in these patients is reassurance. After innocent murmurs, now I shift to congenital heart disease. And the first case that I'm going to be presenting to you in congenital heart disease, I'm going to be talking about congenital heart disease. And the first case that I'm going to be presenting to you in congenital heart disease is of a 6-month child whose mother brings the child to you and tells you, the doctor, my child has not been feeding properly and there is failure to weight gain. My child is not gaining weight properly. He's not feeding properly. And when you examine the child on examination, there is increased respiratory rate of the child. And on auscultation of the chest, you find a murmur, a harsh pan-systolic murmur. A harsh pan-systolic murmur is found at the left lower sternal border, which is 3/6 in intensity. That is, the murmur is pretty loud and is not associated with a thrill. What is the most likely diagnosis? The most likely diagnosis in a patient who presents to you with a harsh pan-systolic murmur, 3/6 in intensity at the left lower sternal border in a child who has failure to thrive, 6-month-old child, is ventricular septal defect. Ventricular septal defect is the most common congenital abnormality in the heart. It can occur either alone or in association with other congenital abnormalities. Patients' clinical features depend upon the size of the defect. If the defect is very small, the child presents to you asymptomatically, and this murmur might be picked on routine examination of the child. If there is a large murmur, then the patient might present to you in a heart failure. The patient might have a large left to right shunt. See, in ventricular septal defect or in any defect, for example, ventricular septal defect, atrial septal defect, patent ductus arteriosus, what happens is that there is left to right shunt. The blood flows from the left side of the heart to right side of the heart. Because there is increased pressure in the left side of the heart, the blood will go from high pressure to low pressure. So the blood flows from left side of the heart to right side of the heart. In this case, the blood will flow from left ventricle to right ventricle through the defect, and from the right ventricle it will enter into the pulmonary circulation. And if the defect is large volumes of blood will be diverted to the pulmonary circulation and chronic increase in the blood flow to the pulmonary circulation will lead to pulmonary hypertension, pulmonary hypertension, which will lead to hypertrophy of the tunica media of the pulmonary arteries. There is chronic pressure overload, chronic volume overload in the pulmonary arteries leads to hypertrophy of the tunica media. There is hypertrophy of the tunica media in the pulmonary vessels, and this hypertrophy of the tunica media will lead to gradual narrowing of the pulmonary blood vessels. Due to the narrowing of pulmonary blood vessels, there is gradual increase in the pulmonary blood pressure, and when the pulmonary blood pressure becomes equal or greater than that of the pressure in the systemic circulation, pressure in the left ventricle, this left to right shunt will now shift from left to right shunt to a right to left shunt. The blood will now flow from right side of the heart to left side of the heart due to pulmonary hypertension. So in this stage, when this stage is reached, then this is called as Eisenmenger syndrome. That is, what is Eisenmenger syndrome? Eisenmenger syndrome is when a left to right shunt is converted to a right to left shunt over a period of time. Eisenmenger syndrome, and this is a very important event because then in a right to left shunt, the deoxygenated blood is going directly into the systemic circulation without being oxygenated, and these patients will become cyanotic. They will present to you with clubbing of the fingers, and they will present to you with all the features of cyanotic heart disease. Initially, the disease starts as an acyanotic heart disease, but if the patient develops Eisenmenger syndrome, then these patients have a cyanotic heart disease, and these patients can rapidly develop heart failure. So after you examine this patient, take the history. How do you diagnose this case? Well, all these congenital heart diseases are diagnosed by an echo. Although other tests such as a chest X-ray and EKG can also be performed, but the definitive diagnosis is by an echo, which will not only show the size of the shunt, size of the defect, but also tell you the shunt that is occurring across that defect. How is it treated? How is a ventricular septal defect treated? Well, if the defect is small, then in 30 to 50% of these patients, the defect will close itself by 2 years of age. If the defect does not close by 2 years of age, and if the defect is large, then surgical treatment is required for these patients. Surgical treatment is required, and along with that, if the patient develops heart failure, then medical treatment is required to control that heart failure. And along with all this, endocarditis prophylaxis with antibiotics is also required in all these patients, because ventricular septal defect patients have an increased risk of infective endocarditis. So prophylaxis for infective endocarditis is also required. And another complication is heart failure, which needs to be controlled. Early diagnosis and treatment of ventricular septal defect will prevent all these complications, and they can lead a normal, healthy life. So that is all about ventricular septal defect. Now we'll be talking about atrial septal defect in congenital heart disease. Atrial septal defect obviously is a defect in the atrial septum, which can occur anywhere in the atrial septum, but most commonly it occurs in the ostium secundum. So most common defects in the atrial septum are ostium secundum defects. How do these patients present to you clinically? What are the clinical features? Well, most of these patients are asymptomatic. Many of these patients will present to you in an asymptomatic way, and when you do a routine examination, you will find a murmur located at the left mid-sternum or the left upper sternum, which will be an ejection systolic murmur, 2/6 or 3/6 in intensity without a thrill. Usually there is no thrill associated with an atrial septal defect because there are decreased pressures, there are low pressures in the atria as compared to the ventricles. So the pressure difference is not that high to produce a thrill. A characteristic finding of atrial septal defect along with the murmur, and a more characteristic finding actually than the murmur, is widely split second heart sound. Widely split S2 is the most characteristic finding of the atrial septal defect, and you must never forget this. Widely split S2 is the most characteristic finding, and if you find this finding in a young child, then you're most likely that you're dealing with a case of atrial septal defect. And the clinical features, the rest of the clinical features are similar to that of ventricular septal defect. That is, with the passage of time, these patients might develop Eisenmenger syndrome, and when the Eisenmenger syndrome develops, a left-to-right shunt is converted into a right-to-left shunt, and the patients develop a cyanotic heart disease and heart failure develops. How is it diagnosed? It is diagnosed by an echo. An echo will show the size of the defect and the shunt as well. How is it treated? Well, the treatment is surgical, either open heart surgery, or it can also be done by occlusion devices, various occlusion devices. What are the complications? Well, in contrast to ventricular septal defect, in which there is a high incidence of endocarditis, in patients of atrial septal defect, the incidence of endocarditis is so low that no antibiotic prophylaxis, no endocarditis prophylaxis is required for these patients. Although these patients can develop heart failure when the left to right shunt is converted into a right to left shunt after Eisenmenger syndrome develops. So they can develop heart failure, they can develop arrhythmias, they can develop valvular insufficiencies, but endocarditis is not a feature of atrial septal defect, therefore they do not require any prophylaxis. The next topic that I'm going to be discussing is patent ductus arteriosus. Patent ductus arteriosus. Obviously, in patent ductus arteriosus, what happens is that there is failure of closure of the ductus arteriosus. And ductus arteriosus is a duct which connects the pulmonary artery to the aorta. It's a duct which connects the pulmonary artery to the aorta, which is present in the fetal life. And it is a very important duct in the fetal life. But as soon as the child is born, as soon as the fetus is born, this duct closes. Why does it close normally? Well, in the fetus, this duct is kept patent by various prostaglandins. For example, prostaglandin I, which is also called as prostacyclin, and prostaglandin E2. These are the prostaglandins which keep this duct open in the fetal life. As soon as the child is born, the blood vessel, the pulmonary arteries, the pulmonary artery undergoes, the ductus arteriosus undergoes muscular hypertrophy. The ductus arteriosus undergoes muscular hypertrophy and becomes relatively insensitive to the dilating effect of these prostaglandins, and relatively increased sensitivity. There is relatively increased sensitivity after birth to the constricting effect of oxygen. When the lungs inflate, there is increased oxygen concentration in the pulmonary circulation, in the aorta. So that increased oxygen concentration will lead to closure of the duct due to constricting effect of the oxygen. That is the proposed mechanism for the closure of the ductus arteriosus. So a patent ductus arteriosus will occur in any instant in where the dilating effects of these prostaglandins are prolonged. And it usually occurs, the incidence of patent ductus arteriosus is increased in premature infants, because in premature infants, since they are not fully mature, the vasculature is not fully mature, the prostaglandins still have their dilating effect on the ductus arteriosus, so the ductus arteriosus remains open even after birth. So, how do these patients present to you clinically? What are the clinical features? Well, these patients might present to you clinically depending upon the size of the patent ductus arteriosus. If the size is large, these patients might be symptomatic. If the size is small, they might be asymptomatic. In large patent ductus arteriosus, you might find bounding peripheral pulses. There might be wide pulse pressure, bounding peripheral pulses, wide pulse pressure, and a machinery-like murmur is the characteristic murmur of patent ductus arteriosus. Machinery-like murmur, which is not a systolic murmur, it is also not a diastolic murmur. It occurs both in systole and diastole, so it extends throughout the heartbeat, systole and diastole. This murmur occurs both in systole and diastole. It may be associated with a thrill as well, and when you see the apex beat, when you examine the apex beat is usually heaving in these patients. So, how do you diagnose a case of PDA? The diagnosis is by an echo. How do you treat it? Well, there are two aspects of treatment of patent ductus arteriosus: medical treatment and surgical treatment. If the infant is premature, then most likely the ductus arteriosus will close itself over a period of time, and you can also use indomethacin in these patients. As I mentioned, prostaglandins keep the ductus arteriosus open, and what indomethacin does is that it inhibits the prostaglandins, so it helps in closure of the patent ductus arteriosus in some cases. So in premature infants or any infant who's born with a patent ductus arteriosus, initially medical therapy is tried with indomethacin, and if the medical therapy fails, then obviously surgical closure may be required after infancy. If the patent ductus arteriosus remains patent, if the ductus arteriosus remains patent after infancy, then definitely surgical closure is required.